Myself, Dr. Somnath Mahe, MD physician. I'm working at Bharaj Hospital, Hoshiarpur, Punjab. Today I'm going to talk on latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable disease, of which 27% are attributed to CVDs, which affect 45% people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively as per WHO. Despite that, nearly half of the people of, or 51% of the men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigm attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standard refer to minimum standard of care to allow specification of essential standards of care low resource settings. The AHA-ACC has released a scientific statement in 2021 offering a new guideline for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low-risk adults, that is, no ASCVD or 10-year CVD risk of less than 10%, with stage 1 hypertension, that is, systolic blood pressure of 130 to 139 and diastolic of 80 to 89. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Acute respiratory distress syndrome, ARDS, is potentially fatal condition involving lung damages, and experts often associate it with severe COVID-19. A recent study which appeared in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure target down to the 110 to less than 130 millimeter of mercury range substantially reduces cardiovascular adverse events in the STEP randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV. Findings from now our second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 millimeter of mercury. With regards to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guideline on the Management of Arterial Hypertension recommends that the diagnosis of hypertension should not only be dependent on office BP measurement, but also on out-of-office measurements such as ambulatory blood pressure monitoring or home blood pressure monitoring, that is ABPM or HBPM. 24-hour and nighttime BP measurement were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurement for estimating CV risk. For every 20 by 10 millimeter of mercury increment of BP measured at night, the risk of mortality increases by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. 2018 European Guideline equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination therapy is particularly highlighted to improve the adherence to therapy and BP control. Therefore, the 2018 European Guideline recommends, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor 1 or ARB plus calcium channel blocker or diuretics. Since early 2018 July, products containing valsartan have been recalled worldwide. The reason is detection of a known carcinogen, namely N-nitrosodium sodimethylamine, that is NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 100,000 patients would have received NDMA contaminated valsartan from Zhejiang, Hawaii every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 100,000 patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of +6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment in this trial. Chronotherapy was associated with significant reduction in endpoint, including deaths. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon wakening hypertension therapy exert a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients. During an adverse follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. Thank you very much.